My name's Wes. I'm one of the pediatric neurosurgeons just down the street at Boston Children's. So I didn't have to drive too far, but I know a lot of people have traveled quite a ways, so I can appreciate that, and I appreciate you guys coming to this talk. I promise I'm not going to make this super boring and technical. I want to make it accessible, and I want to make it interesting, and hopefully it can give you guys some information and answer as many questions as you have. So we'll try to emphasize the question answering period as well. But I definitely don't want to be too formal, so please feel free to raise your hand at any time and ask any questions if they pop up. But otherwise, we'll have at least 15 minutes towards the end to talk about questions. I actually do epilepsy surgery at Boston Children's, but I also take care of kids with tone, which is to say too much tightness in the arms, legs, or other parts of the body. And today we want to talk about some surgeries that we use to help kids that have too much tightness or too much tone that's impairing quality of life. And I think that's really the key for us, is we're not really just trying to decrease tightness for the sake of that. We want to decrease tightness in patients so that they can walk better, so that they can be more comfortable, so that they can do the things that they want to do. And we're going to talk about a surgery called Rhizotomy. That's a surgery where we're actually operating on the nerves that come off of the spinal cord and go down the legs when they create too much tightness that impair kids' ability to walk, to get around. And this can happen from a number of different reasons. The most common that we treat is actually cerebral palsy. But it can also happen after epilepsy surgery too, as I'm sure you guys know. And so we'll talk about when we do this surgery, when it's applicable to kids with epilepsy, and how it might help in certain circumstances. So we'll start just by going through an overview of what this surgery is. And there's essentially, we call it rhizotomy. There's essentially two flavors of this surgery. One of them you might have heard of as SDR. It's also called selective dorsal rhizotomy. That's a surgery that is usually designed for kids who are walking with or without assistance in order to make them walk better. The other type of surgery down here on the bottom, combined rhizotomy, is a different flavor of the same surgery that's designed for kids who aren't able to walk but have such bad tightness and tone that it impairs their quality of life on a daily basis. And so we're trying to help loosen or relax that extra tone so that people aren't so uncomfortable and can be more functional. So we use the word spasticity to talk about this tightness that happens after something occurs in the brain. And that can be an epilepsy surgery, that can be being born with not enough oxygen as a baby, cerebral palsy. It can be something that happens after a bad car accident even. But all those things, when they create damage to the brain tissue, it essentially means that the leg and arm on that other side is going to have extra tightness and tone, and that can impair quality of life. We call that spasticity, but it's more than just tightness. It actually has to do with coordination of the body too. So it's not just being too tight, but it's also not being able to use that arm or leg very well. And that's what spasticity does. And it usually gets worse over time rather than better as people get older. And so that's why we often do this surgery for kids who are around the first decade of life, so around 3 to 9 years old. But we sometimes do it outside of that age range too. Anytime that people have too much tone or too much tightness that's affecting their quality of life, we definitely don't just jump to surgery. We go through a list of other options that are less invasive first to see if they help solve the problem. And that includes physical therapy. That includes some medicines that help reduce tightness, like baclofen. And it also includes injections into the parts of the arms or legs, like Botox. And so some of us, are familiar with Botox in different contexts, like migraines or even for facial wrinkles. But we actually use it in our patients with tone to decrease the tightness so that kids can use their arms and legs better. And sometimes we get into a cycle where we say, well, the Botox is working, but gosh, I have to have it done every 3 months. and I would like to have something more permanent so we don't have to keep having those injections done. And that's sometimes why we see patients that come to us for surgery. The surgery we're talking about, called rhizotomy, is something that's evolved a lot and become a lot less invasive over time. It used to involve a really big opening on the back where doctors would expose a large window of bone and all the levels of the nerves that come off of the lower back down to the legs. And now, thankfully, we're able to do this through a much smaller opening, and that's a lot less invasive. It's a lot less pain and easier recovery for kids. So we've made this a much more minimally invasive surgery over time. You can see these pictures here are actually from an ultrasound. And this picture on the far left, you can see this triangle shape. That's actually the end of the spinal cord. And that's where the whole surgery takes place, at the very end of the spinal cord, where all the nerves come off that go to the hips and legs. And that's where we find the nerves that are making the worst tone that are going to the legs. And we actually operate on small parts of those nerves that carry the worst signals of tone so that we can help decrease that. We actually use neuromonitoring during the surgery, which means that we have a special technician that is checking all the nerves for us so that any nerve we select in surgery, they can say which nerve that is, and also we can make sure that we know which are the bad nerves and which are the good nerves that we want to leave behind. These are a couple of illustrations just showing what we were describing. You can see on the upper left the end of the spinal cord, and those little yellow hooks are essentially picking up under a microscope each nerve individually, and we're testing them to figure out where the bad actors are that are creating too much of that tightness. And then we make small cuts on the part of the nerve where too much of the abnormal tone is going through, whereas we leave behind the rest of the nerve that doesn't have that bad signal. And the end result of that is a lot less of that abnormal spasticity. And that means that people can walk better, can use their arms and legs better, and are more functional. And sometimes we actually will work on the nerves that are on the deep side of the spinal cord too, which are the ones that go directly to the muscles. We only do that in patients who are not able to walk, and if we really want to just decrease tone for comfort. So that's kind of the two different flavors of the surgery, and they have two different reasons that we do them. So I want to mention cerebral palsy for a second because this is the most common reason we do this surgery. And I think it's important to understand who most patients are that are getting this surgery. And we mostly do this surgery for kids who use both arms really well but have trouble with both of their legs. And the term we use for that is spastic diplegia. That's something usually from birth-related injury or, for instance, not getting enough oxygen to the brain during delivery. And it can really help kids walk a lot better. We know that it lasts permanently. So we have data for about 30 years showing that it doesn't actually decrease the effects over time or doesn't wear off. So we know that it is a permanent way of controlling that abnormal tightness or abnormal tone. It improves function and walking, just like we mentioned, and most patients, so about 50 to 70%, improve at least one whole level in their independence, which means that previously they were using a walker, now they don't need a walker. That's an improvement of a whole level. Some patients still need orthopedic surgeries. For instance, if their hip is dislocated from having so much tone, or their knee or ankle joints are not working properly. It doesn't mean that you don't necessarily need other surgeries like that, but you might need less of them. And that's one benefit from controlling the tone, because we talk about it kind of like a waterfall, that it all sort of goes downhill. It starts with the brain and with the tone, and when the muscles get too tight, it pulls on the tendons get shortened and contractures happen. Then it pulls on the bones and people develop orthopedic abnormalities. So it's this waterfall of problems that cascades down from starting with too much tightness. And so that's why we try to address the tightness first to prevent all these other problems. But sometimes if they've already happened, we still will revisit the tone. The best candidates for SDR classically are felt to be kids who are either walking on their own or walking with some help. And you can see this top row, of these three different categories are showing different functional levels for kids. And this one on the far right is called level 3, and these are patients who sometimes use a wheelchair, sometimes are able to walk under their own power, can still benefit from this surgery. But if patients are too weak to support themselves with their own legs, then we usually don't do this type of surgery because we're really trying to take the walking and make it even better, make it even more effective. This is the way we've traditionally thought about tightness. Patients who have tightness in both arms and both legs have typically been candidates for a surgery called a baclofen pump, which is a pump that goes under the skin and puts relaxing medicine onto the nerves in the spine. And kids who have tightness mostly just in the legs have been candidates for the surgery we're talking about today. You may have heard of this condition called dystonia, which is also something where we will do a surgery called deep brain stimulation. But you'll notice on here, weakness of one side of the body alone, or hemiparesis as we call it in spasticity, is not on this list. And that's an important thing I wanted to talk about today, is that kids who have epilepsy surgery on one side of their brain and have corresponding weakness and spasticity on the other side are not traditionally thought of in this same scheme, but actually can still benefit from this procedure. And so I wanted to show you kind of where we've come and where we are going, as we go down the road. And we will talk about specifically for epilepsy surgery as we kind of build up where this has all come from. And just like any surgery, there are reasons to do it and reasons not to do it. And we specifically don't offer this surgery for patients who are less than 2 years of age, because sometimes when you're that young, the tightness can actually get better on its own. And so we don't offer it before then. We also want to make sure that patients who get this surgery are able to really participate in therapy. They have to be able to do what I say is the main part of the surgery. The small part is the part we do in the operating room. The main part is what kids do when they're done with surgery, and they have to work really hard with physical therapy to get stronger and stronger and rebuild the strength when we take away that crutch. And that's the way we talk about it. It's essentially like having a cast on your leg or a crutch, having all that spasticity. The muscles are actually quite weak under that because the spasticity is like a fake strength. It's a tightness, but it's not a real strength that they're using. And when we take away that abnormal tightness, that spasticity, the leg underneath is quite weak. And so we have to build up that strength with weeks and weeks of therapy. And we describe it as I call it the boot camp, when kids will go to inpatient rehab and work to get as strong as possible after surgery. That's very important. So kids who aren't able to undertake that therapy just don't get as much bang for their buck out of the surgery. And so that's why we try to make sure that kids are able to do that before we offer surgery. Also, just like any surgery, there are potential complications in doing this surgery. One of them is that we have to make a small opening in the bone to get to the nerve sac where all these nerves are. And it used to be with that big opening that I was talking about, people making decades ago, it could allow the back to lose some of its support and need to have screws and rods put in to be straight. That's very, very uncommon now that we make a much smaller opening. It's also common to have a little bit of, we call it sleepiness in the bladder or urinary retention right after surgery, but that's very temporary. In one series here of almost 4,000 patients, permanent changes to the bladder were 0%. So this is a temporary phenomenon. We are working inside the nerve sac where the spinal fluid is. So we have to get a nice watertight closure of the nerve sac when we're done. And if that doesn't happen, there can be spinal fluid leakage under the skin that can form like a big bubble under the skin, or it can even leak, requiring another surgery. That's not common, but it is possible. And actually, the complication rate for this surgery is much lower than putting the pump in overall. We know that there's a lot of information supporting why the surgery works and how it works, going back to the 1970s, and several randomized controlled trials as well in the late 90s that show that the surgery works. And we know that it lasts for a long time. At least the data we have going back over 30 years shows that it doesn't drop off over time. we know that certain patients do better than others, and the biggest thing is the one we already talked about, which is being able to participate with therapy and really get the benefit from the surgery. We know that patients who have had a whole lot of surgery on their joints just won't be able to walk quite as well usually as patients who haven't had all those contractures develop yet from that waterfall effect that we talked about. So we like to see kids younger if we can. There's also reason to say that we still don't understand who the best patients are for surgery yet. And more recent literature is showing us that some of the reasons we thought are the best reasons to do surgery 30 years ago aren't necessarily the best reasons to do surgery anymore. And epilepsy surgery is a perfect example of that. We mentioned that these effects are durable or long-lasting, and we know that that's the case over at least 20 to 30 years. But I did want to spend just a minute talking about what about those patients who are in a wheelchair who are unable to walk. And for me, the surgery is used only in the event that we need to get better comfort and better control of tightness, and something that actually affects people on a day-to-day. We have to do a different flavor of the surgery for those patients because we also have to operate on the nerves that are underneath the spinal cord. And the reason is if we don't do that, it can unmask something called dystonia, which are in some of those patients, and it can actually make people worse. So that's why we do the different type of surgery for patients who are not able to walk under their own power. We have studied the pump versus the rhizotomy, and this is something we'll bring up because pumps are also used to help control tightness, and found that actually when we wean the pump off and do a rhizotomy after, people usually do better. Although this is still something that needs to be studied more. We know that not only do people do better in terms of their tone, but also they don't have extra hardware in their body that has to have more procedures. The SDR is a one-time surgery, which is an advantage. I know that this is a surgical picture, so I apologize if anyone does not want to see a surgical picture. This is a picture of the end of the spinal cord on the right side, and this little blue band is actually holding up part of the nerve roots so that we can see down to where all the nerve roots are located. This is showing the surgery that we call the combined rhizotomy, and that's, again, this is the flavor that is used for people who are not able to walk, but to reduce the tightness, especially in the hips and legs. And we study that a lot here at Boston Children's. There are a couple of other places in the country studying this surgery. And we know that it really can help make kids a lot more comfortable, can increase quality of life. And that's with a single surgery. It doesn't have to have further procedures down the road. You can see a picture here on the left of the patient who has had a lot of spasticity, but also dystonia, creating a lot of tightness in the legs, but also in this trunk, and is able to sit a lot more comfortably after we actually decrease some of that abnormal signal that's going down to the hips and the legs. And that's an example of how debilitating the spasticity can be for people, and how the surgery is designed first and foremost to increase quality of life. That's really, really what it comes down to for us. Now we're going to hone in a little bit on epilepsy. So I'm going to start talking about a couple of things where we're learning what can this surgery be used for other than the cerebral palsy group. The first one is for patients who've had an injury to their brain from accidents, from being in a trauma. And we're seeing a lot of that this summer, certainly in our hospital, I'm sure with other hospitals too, a lot of trauma. That can create, after the brain damage that occurs, it creates tightness on the opposite side of the body. And we know from studying this that doing rhizotomy in patients who've experienced trauma can actually not just decrease the tightness, but can improve the ability to walk. And for instance, it can be used from patients who are bedbound in a wheelchair to being able to use crutches afterwards, just by being able to increase levels of function. But the point here is that we're still learning who can benefit and who doesn't benefit from this surgery. We know that it can work for patients who have weakness just on one side of the body or tightness on just one side of the body. And this is a study of 13 kids. So again, this is not a lot of patients, but this is a study of 13 kids who, for several different reasons, had a pattern of spasticity that was different from the cerebral palsy group we talked about earlier. And the reasons for this could be injury to the brain, like brain hemorrhage, trauma, traumatic brain injury, or brain tumor. And whatever the reason was, it was creating that spasticity on just one side of the body. And we saw from this study that all the patients in this group had a decrease in their tone or tightness, which is what we expect, but also their families reported improved gait quality, or in other words, that they were walking more effectively, that the length of their gait, their stride, got longer, and that they required less orthopedic surgeries because the tightness was not as high, and therefore it wasn't pulling on those tendons and those bones that require the orthopedic surgeries later. So now really getting to why you guys are here today at this conference with epilepsy. And this surgery specifically at our hospital, is unbelievable in terms of its effectiveness for certain patients with epilepsy, which is the hemispherectomy, also called hemiparesis. And of course, that's when one whole half of the brain is disconnected from the other half. And that's in order to prevent the seizure activity from worsening. In fact, it can be really amazing for certain patients. But when you disconnect half of that brain tissue, it creates the same effect that we were talking about, where the other side of the body, arm and the leg, can develop spasticity. And spasticity, just like we mentioned, is not just tightness, it's also difficulty using those body parts, not just that they're tight. And so this is something that is currently under study. I want to make sure we're really clear about that this is not something where we have 30 years of experience saying, thousands of patients have been treated. This is a very, very new cutting edge usage of this surgery. I want to make sure that we mention that. But what we're seeing is really exciting in the sense that even with the smaller surgery, the one where we only operate on the nerves on top, the SDR, we're seeing patients have the same things we look for in our other patients, which is not just decreasing tightness in the opposite side of the body, but being able to walk better and walk longer with less fatigue, because they're not fighting that tone, that abnormal tightness. That means that kids can run, jump better, play more effectively, and can hopefully have a better quality of life. This is something I made a bullet point here towards the bottom that people are worried about, which is sometimes if we take away that spasticity in the wrong patient group, we can unmask something called the dystonia and make patients worse. In this group, we did not see any unmasking of dystonia, and that's really reassuring to know that we don't have to do the second flavor of the surgery where we operate on the bottom nerves too, that just the basic SDR surgery for kids with hemispherectomy can control tone and improve walking. And this is a study which has 5 years of follow-up. There are 2 patients. I wanted to highlight each patient just to show you how rarely applied the surgery is so far and how much we have to learn about it. The first patient here, this is a patient who had a hemispherectomy at 10 years old. They were having worsening epilepsy as a result of a congenital brain malformation. And just like we expect, their epilepsy, their seizure control improved dramatically after surgery, which is fantastic. But the opposite side of the body has weakness as well as spasticity. So walking became very difficult. The SDR was done in this patient just over a year, so about a year and a half after the seizure surgery. And this patient also had developed contractures in their tendons, which we talk about coming from the tightness. And so they had to have orthopedic surgery to lengthen the tendons as well, to try to make the legs work as well as possible. For this patient, the SDR eliminated the spasticity, in other words, decreased that tightness. We also see exaggerated reflexes in patients with spasticity, which is that jerking, sort of fluttering that we see at the arms and legs. And that's a hyperreflexia, or a really, really jerky, increased reflexes. SDR is really good at decreasing that as well. And in fact, normally after I treat patients with SDR and patients who have sustained, if this is their feet, fluttering, and we call it clonus in the feet, normally goes away. In this patient, the family reported walking, balance, sitting, and standing were improved, and less fatigue, again because that tightness was decreased. And in this, in the second patient, this is a patient with Sturge-Weber who had refractory epilepsy from that, and had to have a right-sided hemispherectomy. Their epilepsy surgery was done in England, and this patient was able to walk, but again, their walking was limited by the tightness on the opposite side of the body. And just like the previous patient, that tightness led to contractures, or tightness of the tendons, that required lengthening by the orthopedist. The SDR surgery also decreased tightness in this patient, and allowed for continued improvement of walking with physical therapy, like we talked about earlier. So much importance with the physical therapy. And also the foot function improved once the orthopedists were able to lengthen that tendon. The problem with shortening these tendons from the tone is that sometimes the orthopedic surgeons will go and say, well, okay, well, we're going to lengthen that tendon again. But if we don't treat the tightness that's underlying it, it becomes short right back again. And so we work so closely with our orthopedic surgeons because we want to do things in the right sequence to help patients have less surgeries. And so now that we talked a little bit about epilepsy, this is, again, the classic criteria for this surgery for patients. We look between the ages of 3 and 21 for our hospital. Mostly patients that have tightness in both legs, but also I put here in orange, this is now an area of research for patients who have spasticity on one whole side of the body, especially that leg, as a result of epilepsy surgery, or other causes, like we mentioned, brain tumor, hemorrhage, or trauma. GMFCS is that functional status that we showed with the cartoon of kids in different functional levels who are walking or using a wheelchair. So those top 3 levels are GMFCS 1 to 3. Those are patients who, again, they're able to walk either with or without assistance, and those are the patients who we know if we can decrease some of that tightness and get them to rehab, we can get them stronger and walking better. We try to avoid doing this surgery of patients who can't participate in PT or have such severe damage to their brain that they can't undergo that process of learning how to walk better. So the question at the end of the day, does this surgery work for spasticity with kids who only have their spasticity on one side of the body? The answer appears to be yes, but with a big asterisk, which is that this is a group of patients that still really have to be studied and that we're still learning about constantly. And so we follow the same algorithm that we do for treating any patient, which is that we have a very big multidisciplinary team, more than just us as the surgeons, physical therapists, orthopedists, physical medicine and rehab doctors. We all work together to figure out, have we done everything else besides surgery in terms of physical therapy interventions, less invasive surgeries that can be done to make sure that we're doing things in the right sequence. And if patients have not been able to progress or haven't been able to make adequate gains in their function, then I think it's important for families to know all the different options that are on the table. And I think if the tightness is limiting somebody's function or ability to walk, then we should know that that's an option. And so I think my biggest take-home point here is that SDR is just one tool in our toolbox. We really try to evaluate kids in a multidisciplinary big team, like I was just mentioning. And oftentimes SDR is not the right surgery for a patient. Sometimes it's a great fit for the right person. It can make a really big difference in quality of life. But I think we have to really think about it from the perspective that this is a new application of this surgery and that it needs to be studied. We need to be following kids for long term to make sure that it's safe and that it's doing what we want it to be doing. But we know that it works really well in other populations of kids that we've done for several decades. So I don't want to talk for too long. I want to make sure we're able to answer questions. This is my email, so please feel free to shoot me an email anytime. Even if it's not about tone surgery, if it's just about seeing, our multidisciplinary team, I'm happy to help try to connect you to the right folks. And I appreciate you letting me talk, so thank you.
Wondering if you are now evaluating patients who sort of need that have candidates for SPR, and have any been done?
Yeah, so I think everyone can hear because it's not a super huge room, but the question was, with patients who have hemispherectomies or hemispherotomies, is it a common approach for us to evaluate for surgery like this? And how many patients are getting these surgeries? I think the answer to both is that we have to completely start from the ground up. This is not a traditional part of the evaluation after surgery for patients with hemispherotomy. And honestly, that was the same way with cerebral palsy for a while too, because we would try every other thing aside from surgery. And then we would see kids who are 20 years old where their contractures are so bad that essentially the whole limb is locked into this, I'm literally I saw a patient this morning like that, whose leg is literally locked into a state where it can barely move because the contractures are so bad. So I think institutionally and also as a field, we're trying to learn to figure out how useful this surgery is. And it's not traditionally a part of the workup unless we get to a point where we've said, gosh, we've been trying these medications for a long time and they're not helping. Maybe we should think of alternative options. So I think it should be more routine. And it's something that one of my partners, Skellig Stone, who's an epilepsy surgeon here with me, and I have talked about, but it's not something that's actually a routine part of the care pathway yet. And for us, the huge majority of our rhizotomies are done for cerebral palsy or metabolic disorders as well that affect the brain, but extremely rare for hemispherotomy. And I don't know the real reason for that. I think it's really that we don't know how well it works, and we're very kind of skittish of applying something that doesn't have a long track record. But I think it needs a lot more study, and it needs to be at least brought up as an option on the table if the other things we're doing aren't working. So to answer your question is we're very much right at the beginning of learning about the effects of this. Yeah.
Would the STR be in lieu of tendon shortening or lengthening surgery?
Great question.
Or would it be in conjunction with it? And if so, which would be the order?
So that's a really good question. We always think the important thing is to think about the order of what the tone does over time. And that's why I kind of think of that idea like the waterfall, that the tone starts the process and then it pulls on those tendons to cause contractures. So if we can get ahead of that, if we can treat the tone before it creates all the downstream problems, it can help avoid surgery. But sometimes it can't. Sometimes people will still inevitably need to have a tendon lengthening surgery, but it's a lot less surgery, and hopefully they require less of them over time. So that's what I always tell families with this surgery, with SDR, is that it's not going to prevent you from needing orthopedic surgery, but it might decrease the amount of surgeries that you need, and that's what we see in the literature. So we generally try to do the SDR first, if we can, and then we evaluate patients later on, and very often later on we say, oh, well, actually it's not as bad as we thought now that we're decreasing the tone, so maybe we don't need to go in and do the tendon lengthening. But some patients who definitely have bad enough contractures will do simultaneously. So occasionally the orthopedic surgeons will come in during the same anesthetic and we'll do the tendon lengthening. We will do rhizotomy surgery. And that way the patient only has to recover once from the anesthesia. But I would say we only do that in situations where we're convinced of how bad the contractures are, because we're often surprised how little people need in terms of their tendon release once we've controlled the tone first. Absolutely. Please.
So my daughter is 14. She had a tendon lengthening. She had a second orthopedic surgery that was an epic failure. And now she's suffering from a lot of nerve damage in her foot.
Okay.
So does this have any impact on improving pain from like things like that, like nerve damage?
So there's some good reason to believe that a lot of the spasticity can cause pain and discomfort from chronic tightness. But when it comes to neuropathic pain or pain from actual damage to nerves, it probably won't improve that, or at least it's not designed to improve that. But I think the situation you're describing is one of the situations we run into where it's very hard to tease out, or it can be hard to tease out where the pain is coming from. I'll give you a similar but slightly different example, which is when some patients are so tight that they've dislocated their hip and have a lot of hip pain. Well, our surgery doesn't help hip pain, but it can decrease the tightness that's pulling on that damaged hip, and then it makes their hip pain better indirectly. So I would suspect if what you're describing is a situation of pain from the actual nerves being damaged, the surgery probably wouldn't be able to address that directly. But if any pain is coming from the tightness itself, I think it could help with that. And sometimes we try to tease that out using Botox or using other medicines to kind of simulate the effects of having an SDR, which is a non-permanent way of giving like a strong dose of Botox to say, okay, what would it be like if I had an SDR, if we gave a strong amount of Botox? Is that something that helps, or is it not helping so much? And the good news about that is that if it's not helping so much or we don't like that effect, it's going to wear off in 2 or 3 months. So that's a common strategy we'll use as well if we're not sure. Please.
So my son has resistant epilepsy. He has not had any surgery yet, but we're exploring these options. And he also has spastic Palsy,
Okay.
which has been diagnosed with since a very young age. And so I'm curious if you have any advice for parents, families, patients with kind of both of those happening at the same time, where the epilepsy and the tone are kind of sort of interacting but also separate, and how do you any advice you have for families like ours?
So you actually brought up a point that I didn't bring up, which is a really great one about problems don't necessarily exist independently. Sometimes all these things can be in the same patient. And so we do see a lot of patients with cerebral palsy who also have severe epilepsy. And many of those patients have not had hemispherectomy necessarily, but have had other forms of epilepsy surgery or vagal nerve stimulators, or just on a lot of anti-seizure medications. And so in that group of patients, we try, and by that group I mean patients who have spastic quadriplegia, those are patients where we try to figure out what are our goals overall. And if our goals are to actually decrease some of the tightness to improve comfort and improve quality of life, sometimes SDR can be really useful. And the reason is because that group of patients, spastic quadriplegia, would otherwise usually be candidates for the baclofen pump. And sometimes that's a lot to put on someone's plate, having repeated surgeries or repeated procedures. The pump works great for some patients, and I don't mean to suggest otherwise. But it's not for everyone. And sometimes if we can do a single surgery to decrease the tone and tightness and not have to put a baclofen pump on someone's plate, that can be a lot more effective than adding other medications like the baclofen, adding other procedures, routine refills of the pump, replacements of the pump, etc. So what I'm getting at there is that patients who have a lot of medical complexity, sometimes benefit from having less on their plate and not more. And that's why I think for some families the rhizotomy is a better fit than the baclofen pump is. But we always try to present both of those options just to figure out which would work best for a given family. You got it. Please.
Can you explain the difference between spasticity and dystonia? I feel that every time I go to like our PMR, she does the exercise and she says, oh, she's clicking here, and I feel like she said spasticity is good, but then it's also can be inhibited. But can you explain that?
Yes. So I actually didn't put a slide in about that, but it's really hard to tease apart these two things. So when we think about somebody who has tone, which is to say tightness, it comes in two ways. One is the spasticity. That's really the jerky, hyper-reflexive type of tone. The dystonia is a little bit different. Dystonia we characterize by these sustained kind of writhing, twisted postures that are held for long periods of time. And we use the term windswept if you look like you're sort of being pushed aside by a really large gust of wind and your whole body is turned to the side. This is a really good picture, actually. This patient who I showed here on the left is a patient who's, if we saw this patient, we would say, oh my gosh, this patient has a lot of dystonia, clearly, because they're sort of locked into this windswept type of a posture. So the dystonia is characterized by these repetitive and also sustained sort of twisting movements that involve more than just the arms or legs, often several different parts of the body. But the really important take-home point is that we often can't tell them apart very well. And the more severe the tightness is in patients, especially with patients with spastic quadriplegia, the more that they tend to come together and to be mixed in. And so sometimes we can say, it seems like someone is mostly spastic or mostly dystonic, but that's actually sometimes hard to say. There's always a little bit of a mixture in patients who have, pretty severe spastic quadriplegia. And that's the real reason why we have that second form of SDR surgery, because if we do a regular SDR on that patient that has dystonia, we unmask that dystonia, which can actually make people worse. So that's why there's those two different forms of surgery. I'm not sure if I answered your question, but I think the main thing is it's very hard to tease apart the two forms. And personally, I think if someone really has spastic quadriplegia and someone says, well, they've only got spasticity or they've only got dystonia, I don't necessarily believe that. I think that the mixture is harder to tease apart. And I think we still have a lot to learn about how we tease it apart. But sometimes that's done with certain medications that work more for one or the other. And actually, sometimes we see it with our surgeries we do, like a baclofen pump that does really well for spasticity but doesn't do so well for dystonia. And oftentimes when we treat someone with a baclofen pump, we can say, yeah, it helped their spasticity, but gosh, they've still got really bad dystonia. And we can see it separate out a little bit like that when we try to treat one side. But I have to tell you that dystonia can be very hard to treat. It can be very hard to separate out from spasticity, and we still have so much to learn about it. So I don't fault the person that you're describing. Please.
If someone has like a very specific focused spasticity issue,
Yeah.
So we do the Botox and it helps the general mobility, but she has a toe that the Botox does very little for. It's always very intense spasticity, makes a lot of her life difficult. Is this procedure something that might help with that level of focused issue?
Short answer, we don't know. I think that it would be a very, very uncommon reason to use the surgery because this surgery is good at kind of getting us to the bulk of nerves that are there. You could still go after certain nerves that are specifically going just to the foot, but it would be a lot of surgery to just focus on the one nerve to go in that region. So I think It would only be done if it was really something where we've tried everything else, and that one part of the spasticity or tightness is really, affecting quality of life on a daily basis, that we would think about something like that. There is something else though, which is that we're talking about operating on the central nervous system, which is the coming off the spinal cord. We also have partners who are peripheral nerve surgeons, which is to say that sometimes we can operate not on the whole bundle of nerves, but just on the actual nerve in the arm or the leg, if that makes sense, or just to focus in on that one nerve. And actually, that can sometimes be a lot more effective. So if I were faced with that situation, I would probably talk to our peripheral nerve surgeons first and say, hey guys, this seems like a lot of surgery just to go after one nerve. Can we just target that one specific part of the foot or leg in the leg itself, rather than having to go into the back? That's how I would personally approach it.
You have partners with it.
Please? Yeah.
No, age 21 is kind of cut off. Is that like your children's hospital? And then what about someone that's like 30? What happens to them? I mean, is it too late at that point, or just at maybe your facility, but?
I think you summarized it perfectly. It might be too late at our facility, but it's not too late biologically to do it. And you're right. Just being a children's hospital, we tend to focus on the group under 21. But we do know from some of my own patients who are over 21 that patients can really benefit from decreasing their tightness and tone, even though they're over 21. What we know for sure is that when you're between the ages of 3 and 7 or 8 years of age, your body you haven't fully learned how to walk yet. And so it's like learning a new language. You're so much better at doing it when you're at that age, but you can still learn later. And so the short answer is we definitely do take care of patients who are in their later 20s, or sometimes even a little older than that. But we know that those patients benefit too.
Is there any good combined?
Good follow-up question there. So for the combined rhizotomy, that actually tends to be an older group of patients for us, and those are patients who have had years of worsening contractures and tightness generally. That's the patient group I most often operate outside of our normal boundary of ages. So for instance, in their mid-20s, late 20s sometimes. So that's because we're not trying to retrain the walking pattern specifically with that surgery. We're just trying to increase quality of life. I'm so sorry, I couldn't hear just the last part of your question.
What are the steps before a family can consider this type of procedure?
I see. So things that we would want to do before considering to actually have an SCR. I think for epilepsy, it's been not even a consideration for a lot of patients for hemispherectomy. And that's something that hopefully will change as we move forward and as we learn more. For patients who have spastic quadriplegia or have spastic diplegia from cerebral palsy, we go through a big multidisciplinary workup where we essentially have patients seen by us as the neurosurgeons, the orthopedic surgeons, the physical medicine, rehab doctors, physical therapists. I think people get tired of how many people come in the room when we do those visits just because it's such a big team. And that's because we think that it's a complex decision-making process. It's not something where we can just say, oh yeah, you're going to be a great SCR candidate. We want to actually make sure we look into every feature that could make someone do well or not do well from rhizotomy. And it's a big change to someone's life, so we want to make sure we're making the right decisions.
I also had another question. Why is somebody thought that the scientific for this
Yes.
but after the kids generally have cerebral palsy as well as hemiplegia. So why are they not considered in the first group of database that we have for traumatic brain injury and hemiplegia caused by reasons? How are those two groups different?
I think so the good question. So the question was, there are patients who have, I'll just advance to that slide, there are patients who have spasticity on just one side of the body for other reasons besides epilepsy surgery. So why don't we kind of lump patients together in one group? And I think we should, from the perspective of where's their tone situated in their body. But I think we are also hesitant. We're hesitant because one of those things is something that we cause with surgery, and the others are things that came from, you know, trauma or brain tumors or things that weren't from a surgical procedure. So I think there's a natural hesitation to say, well, is this the same group of patients? You know, do patients with epilepsy surgery still, you know, respond to this like someone who's had a brain hemorrhage when they were younger? You know, maybe yes, maybe no. And so I think we tend to be overly cautious, which is, in our eyes, a good thing. But sometimes it can prevent us from knowing who the best candidates are for these surgeries. And what we know is that we don't have a lot of experience doing the surgery for epilepsy yet, but that it seems so far, as we know, it seems to achieve the same types of effects that it does in other conditions, which are the ones you mentioned too. Okay, I don't want to talk too long. Thank you guys again, and I'll leave my email up if you have any questions, so thank you.